A che punto siamo con la terapia genica applicata alle persone con emofilia? Quali sono stati i traguardi finora raggiunti? Dove sta andando la ricerca? E inoltre, quali saranno le nuove tecnologie messe in campo per migliorare le cure dell'emofilia? L'abbiamo chiesto a un vero esperto, un canadese, il professor David Lillicrap, che abbiamo incontrato qui a Milano al 18° Congresso annuale dell'EAHAD. Professor Lillicrap, what's about the gene therapy? Which is the present situation, the actual situation, and what's in the near future? Which are the area of research to improve gene therapy?
Gene therapy, which has now been investigated for haemophilia for the past 20 or 30 years, has now reached the clinic. So there are now 2 factor IX gene therapies which have been approved by regulatory agencies and 1 factor VIII gene therapy. The good news is that the factor IX therapies are working very well. There's been trials and people are now beginning to be treated with this in the clinic, and it looks very effective and gives durable factor IX expression at therapeutically useful levels. So I think the story with factor IX is very encouraging, very promising. With factor VIII, it's not quite so easy. There are some patients who've been treated with factor VIII gene therapy who are now out to 7 years with detectable levels of factor VIII of around about 10%, who are not bleeding. But whether this will continue is not so easy. The levels have fallen certainly in the first 2 or 3 years after treatment. So I think we need another generation of factor VIII gene therapy to be better.
Which is the minimal level of factor VIII and factor IX to still work?
Well, we know from natural history of non-severe haemophilia that even if you have levels of 10%, you rarely bleed spontaneously. So I think that even if we can achieve 10% levels over a long time, that would be very beneficial for the patients.
And this happens for gene therapy for factor IX and in a lesser way for factor VIII?
Well, the factor IX levels that have been achieved are around about 30 to 40%. They're very good, in part because we're able to use this hyperactive factor IX Padua gene. So that makes it boost the levels a lot more and gives these levels of 35, 40%, which are now out to 4 or 5 years.
It's a stable...
Stable, yeah. So honestly, the longest factor IX experience was some studies that Dr. Nathwani did back in 2011. Those patients are out to 13 years. So the factor IX gene therapy landscape looks extremely good.
We could say mission accomplished. For factor
Maybe,
IX.
carefully. I think we could say that. With some caution, it looks pretty good.
For factor VIII, what happens? The decline is continuous or at a certain point it stabilizes?
Most of the decline is in the first 2 or 3 years. And then from that point on, the decline is much less. We believe this is in part because we're getting liver cells, hepatocytes, to make a protein, factor VIII, which they normally do not make. And so it may be that once you reach a level of, let's say, 10 to 20%, the liver cells are okay. They say, we can deal with this. And the levels look as though they stabilize much better.
And which are the area of improvement, how to improve the performance, especially that of factor VIII?
There are several studies going on with different techniques to make the factor VIII secreted better, to make it stay in the circulation longer. Those are the major things. I will talk actually this afternoon in my talk about a factor VIII that isn't degraded as quickly by protein C. So these things will get into the clinic maybe eventually. They're all preclinical. So they will maybe get into the clinic in the next couple of years, I would say, but there's still work to do before they become widely used in the clinic.
Changing area, but remaining in hemophilia, you spoke about new technologies. Which are these new technologies that you have described in your lecture?
The new technologies are principally things like gene editing. There are a number of companies now that are beginning to do gene editing. I will talk about one of those where you edit the factor IX gene into B cells, B lymphocytes, and then convert those B cells into plasma cells and give those cells back to the patient. So it's a gene editing process involving another cell type.
And this technology exploits the CRISPR one?
Correct. Yeah. So they use the CRISPR-Cas system to integrate the factor IX gene into the genome of B cells from patients, which are acquired from patients. And then those gene editing cells are expanded and then put back into the patient, the donor patients. There's a clinical trial just beginning using that gene editing method.
And there are other technologies in the near future?
There are other technologies. There's a study that was reported in the New England at the end of last year using lentiviral gene therapy. This is a lentiviral treatment for factor VIII. Currently, there are 5 patients that have been treated with some early promising results.
There are other technology, Professor?
There are other technologies not involving gene therapy. Those technologies are principally using either bispecific antibodies or another new technology called nanobodies. These are small antibody-like molecules, and there's a company now working on those to potentially deliver factor VIII therapy through an oral route administration. So no one's ever thought we could actually give factor VIII orally, but there's a way using these nanobodies which may potentially, after further investigation, be able to do this with oral therapy for factor VIII deficiency.
These nanobodies originally comes from studies conducted in camels, is correct?
Correct. So the camels and related animals do not make antibodies. They make nanobodies, or they make single chain, heavy chain molecules. And if you take a piece of those, these so-called nanobodies, which are about 1/10 the size of a normal antibody, those nanobodies have properties which would allow them to survive in the acidic condition of the stomach and under certain conditions be absorbed through the stomach into the circulation. And so you're aware, many people are aware of emicizumab and MyMate, which are bispecific antibodies. This new innovation would be a bispecific nanobody binding to activated factor IX and factor X in the same way that emicizumab and MyMate act.
So the same target, but with a different technology.
Correct. A very different technology, which has the potential of being absorbed from the stomach into the circulation.
And they are already in clinic or not yet?
No. This is still preclinical, but this was initially discussed at the ISTH meeting last year in Thailand, and the company that's working on this continues to assess the potential of this being getting into the clinic.
So a bright future for patients.
There are many exciting new technologies which hemophilia patients should look forward to.